Hello everyone, this is the second video of Sellar lesions. In the previous video, we discussed about the various masses that involve the sellar and the parasellar region. But in this video, we'll discuss about the physiological, the congenital lesions, the variants which affects the sellar and the suprasellar regions. So let's get on with it. So the first topic that we're going to discuss is pituitary hyperplasia. Now, what exactly is pituitary hyperplasia and how it is different from other mass lesions that involve the sellar and the suprasellar areas? Now, pituitary hyperplasia is diffuse enlargement that can be physiological, that is seen in young females or pregnant lactating women, or very less commonly secondary to any end organ failure. Now, how exactly does it look like? It's basically a symmetrical enlargement of homogeneously enhancing pituitary gland with a convex upper margin. That is a very important thing. There is no focal mass effect or no bone erosion because this is more or less physiological. So there's a dictum that we need to know that an enlarged pituitary gland in a prepubescent male patient is almost always a hyperplasia, and do not term it as a adenoma. That is very important. Now, what are the basic measurements we have to see while measuring pituitary gland? So when we take a core T1 sequence, in which according to age, infants and children have a height of a pituitary gland of around 6 mm. Males and postmenopausal females have a height around 8 mm. Young menstruating females have a height around 10 mm. And pregnant or lactating women have a height around 12 mm. Now, what is non-physiological pituitary hyperplasia? Though it is although less common, it is commonly caused by an end organ failures such as hypothyroidism, Addison disease, in neuroendocrine tumor. Medications such as estrogen, GnRH analogs, and antipsychotics can also exacerbate pituitary hyperplasia. So that's why it's very important that in case of pituitary lesions, as we have discussed in previous video, the age, the clinical presentation, the history, the hormonal workup, the biochemical, the blood workup is really important to approach, to move to confirm the diagnosis that we are thinking of. Now, here we can see there's a pregnant woman. There's a pregnant woman in a 38 gestational week. She presented with a 2-week history of visual disturbance that involved the right temporal superior quadrantopia. The TSH was 1.83. Other hormonal prolactin was highly raised. So at 38 weeks, you can see the pituitary gland is this is SAGT1. This pituitary gland is enlarged and demonstrates a avid contrast, homogeneous contrast enhancement. It demonstrated avid homogeneous contrast enhancement. Now the gland extended to the supracellular cistern and it elevated and compressed the optic chiasm. That's why she was having visual complaints. The pituitary stalk, it was nearly in midline and appears normal. Now after delivery, the size, the craniocaudal distance of the pituitary gland decreased. Followed up by after 5 months, there was again decrease in the craniocaudal distance of the pituitary gland. So it was resolving. It's seen in pregnant women. So that was this is a case of pituitary hyperplasia. Now, other is empty cellar. Most of us have always heard that node made of empty cellar, node made of partially empty cellar. What exactly it is? Now, in empty cellar, the pituitary gland appears shrunken or invisible. That means the CSF fills the space instead, the pituitary gland is not seen. It is commonly an incidental finding. It has no particular clinical significance, but there exists a well-established association with idiopathic intracranial hypertension. Now, when do we say that this is a complete or total empty cellar or it's a partial empty cellar? Now, a complete or total empty cellar is more than 50% of the cellar filled with CSF with pituitary thickness less than 2 mm. Whereas partial empty cellar is less than 50% of the cellar filled with CSF with pituitary thickness more than 3 mm. Now, what will we get on imaging? Now, the MRI will demonstrate the cellar to be filled with CSF, but however, the infundibulum can be seen to traverse the space, thereby excluding a cystic mass. It means that the pituitary gland, the normal pituitary gland, is compressed because we can see the stalk going through it and is traversing through it. There is no displacement. So this is important. This is known as the infundibulum sign. Now, we have to also rule out in features of intracranial hypertension, although we'll discuss later in other video. But we need to see that intracranial hypertension most commonly correlates with the middle-aged female, and it includes the coexisting orbital findings, that is flattened globes and optic nerve sheath prominence. Now, this was a patient in which we can see that the pituitary fossa is expanded and filled with CSF signal intensity. This is the T1, this is the T2 sequence. Now, the infundibulum is seen mostly as central, not significantly displaced, but we can see the infundibulum traversing through this fluid-filled space. So, we need to know, we need to consider the empty sella as first. Now, on post-contrast, you can see that the thin lining of the remaining pituitary gland is seen at the base of the sella. So this is empty sella syndrome. Now, there are certain congenital lesions that we need to know, the most common of which is hematoma. Now, we need to know that if there is a child and there is a single hormonal deficient, it most or less is the disease is concentrated into the pituitary gland itself. However, if there are multiple hormones that are deficient in a child, then stalk abnormalities need to be considered first. Now, what are hypothalamic hematomas? Hypothalamic hematomas are basically tuber synonym hematomas. These are non-neoplastic heterotopias in the brain. They occur normally in the region of the hypothalamus, arising from the tuber synonym, a part of hypothalamus located between the mammillary bodies and the optic chiasm. Now, it is composed of tissue elements that is normally found at their site, but however, they have grown into a disorganized mass. Hence, we call it as an hematoma. Now, these lesions can cause gyrastic seizures that rapid episodes of laughter with visual problems due to compression of the optic chiasm, early onset of puberty, and behavioral problems. Now, central precocious puberty is also frequently encountered in these children, typically in patients with sessile tumors. Morphology we'll discuss in the next slide. Now, why does it happen? It results from the oversecretion of the gonadotropin releasing hormone, which in turn leads to increase in luteinizing hormone and FSH. Now, this hypothalamic hematoma is also a tuber synonym hematoma. Now, what exactly is tuber synonym? Now, the floor of the third ventricle, from which the pituitary stalk, from the pituitary stalk to the mammillary bodies, is called the tuber synonym. This area, that is the floor of the third ventricle, from the pituitary stalk to the mammillary bodies, is called that area should be tuber synonym. Normally, it should be smooth. Any nodularity within it should raise the suspicion of tuber synonym. That is the importance of tuber synarium. Now, small non-enhancing mass lesion that is contiguous in continuation with the tuber cinereum is always diagnostic of tuber cinereum hematoma. Now, there are two kinds of morphologies. One is the sessile and other is the pedunculated hematoma. Sessile is mostly attached to the floor of third ventricle and it incorporates the mammillary body within itself and projects into the supracellular cistern. Whereas pedunculated is attached to tuber cinereum and projects into the supracellular cistern. As they are composed of gray matter mostly because they are normal tissue, however they are disorganized mass, they have an imaging appearance similar to the normal cortex. They do not enhance and do not grow. Now on CT there will be a nodule of soft tissue that is isotenuating the gray matter without any calcification or contrast enhancement. That is the basic thing, that it should be the intensity of the signal is more or less same as to the gray matter. In MRI it's isointense to cerebral cortex. On post contrast, there should be or there is normally no contrast enhancement. On T2, it is iso to hyperintensive cerebral cortex, and it can have neuronal tissue as well as glial tissue. It depends. If the proportion of the glial cells is more, the T2 signal is higher. On MR spectroscopy, there is a reduced NAS-CRP and increased myonostrol. Increased myonostrol means that there is an increase in the glial tissue. Now, this is a patient. As you can see, there's a soft tissue nodule right over in the region of tuber synonym. Now, this is the floor of third ventricle. You can see it is isointensive cerebral cortex. Basically, the signal intensity is matching with the gray matter, the cortical area, and it is extending to supracellular cistern. There is no avid post-contrast enhancement. You can see there is no post-contrast enhancement. So, the diagnosis was of a tuber synonym hematoma. Now, next pathology is hypophysitis. Now, hypophysitis means that there is an inflammation, basically in simple language, of the pituitary gland, the stalk. Now, lymphocytic is the most common hypophysitis, which is seen in late trimester and postpartum females. Now, here the history is very important. To make a diagnosis of lymphocytic hypophysitis, a strong history correlating with the late trimester, the postpartum stage of the female, is very provides a very corroborative evidence that the lymphocytic hypophysitis should be diagnosed first. Now, on histopathological, they are the T cells predominantly we see in the histopath. Now, it involves both neuro and adenohypophysis. So that means there will be decreased hormones of pituitary gland with increased prolactin due to stalk compression. Now, this is associated with diabetes insipidus. This is very important. This is a strong correlating factor in the history that we should consider lymphocytic hypophysitis, and both intra and supracellular area are involved. Now, imaging. Imaging is that it is a small, less than 3 centimeters, symmetrical pituitary expansion with loss of normal T1 bright spot. The stalk is enlarged and it's not tapering with homogeneous contrast enhancement. Now, it's a very close differential of a pituitary adenoma. Now, how to differentiate it? A pituitary adenoma is seen in older patient. It is increased, has increased size with size more than 3 centimeter. It causes an asymmetric pituitary expansion. Here, it was a symmetric pituitary expansion. Now, this asymmetric pituitary expansion causes cellular remodeling, as we discussed in the previous video. Stalk is displaced, however, but it is normal in thickness. In hypophysitis, the stalk is involved. Now, there is an heterogeneous moderate enhancement in an adenoma, whereas there was a homogeneous contrast enhancement in lymphocytic hypophysitis. This was a patient in which you can see that there is thickening of the centralized pituitary infundibulum, that is pituitary stalk, with more diffuse enhancement. There was no focal lesion or no abnormal enhancement of contour abnormality, no paracell or supracellular lesions, and the optic chiasm more or less normal, and the cavernous sign is also more or less normal. Now, if this patient presented in late third trimester postpartum with hormonal problems in a female with such a homogeneous contrast enhancement involving both the gland and the stalk, we should first consider lymphocytic hypophysitis as a differential. Now, the next is granulomatous hypophysitis. Now, it is a rare inflammatory disorder, commonly affects females, and it is associated with sarcoidosis, tuberculosis, fungal infection, syphilis. So, again, history plays a very important role in this. Again, the stalk and the pituitary gland is both of them are involved. Now, how history is important, that a particular patient comes with shortness of breath and lymphadenopathy in chest. Now, when she's having hormonal complaints and headache or decrease or some visual disturbance can be present at times. Now, when you do an MRI, you can see that the pituitary gland is infundibulum, diffusely and homogeneously enlarged, and there is diffuse intense enhancement. And no pituitary or supracellular extension is noted, no bony remodeling or erosion or any cavernous sinus involvement is seen. So, in this clinical setting, with shortness of breath and lymphadenopathy in a female, this all points that this is a case of hypophysitis, likely granulomatous. The main etiology could be sarcoidosis, and we need to further do workup for sarcoidosis. This is how you approach with clinical presentation and the imaging. Now, one more syndromic management syndrome is the LCH, Langerhans histiocytosis, which is commonly involves the pituitary stalk and the pituitary gland. Now, CNS manifestations, that these are generally basically involving three distinct clinical presentations of the LCH. One is neurogenic, that is central diabetes insipidus. Second is neurodegeneration, characterized by psychomotor deterioration or ataxia, and third is obstructive hydrocephalus. This is how a CNS manifestation of LCH presents. First is diabetes insipidus, neurogenic. Second is neurodegeneration, characterized by ataxia or psychomotor deterioration. And third is obstructive hydrocephalus. Now, CNS involvement rarely occurs in isolation. Thus, patient tends to present with other manifestations of LCH as well. So, if a patient is presenting with LCH and the imaging are pointing towards LCH, you need to do further workup of LCH of the patient. Now, how LCH affects the pituitary and the stalk? Now, as we have seen in the previous slide, the most common presenting feature was central diabetes insipidus. This is the most common CNS manifestation of LCH. Patient with diabetes insipidus demonstrates a lack of T1 weighted hyperintensity of the posterior pituitary gland, which means that the normal posterior bright spot is gone, associated with enhancement, and there is thickening more than 3 mm of the infundibulum. This loss of the normal pituitary bright spot is thought to be a result of the loss of vasopressin, and this is the reason why the patient is suffering from diabetes insipidus. Now, the most clinical CNS manifestation of LCH is diabetes insipidus, that is secondary to infiltration of the posterior pituitary gland. Now, this was a patient. Now, here there's a supracellular mass lesion with hyperintense signal T1 with intense contrast enhancement and thickness of the infundibulum is also involved. The pituitary stalk is involved. There is a loss of the normal T1 bright spot. With other features associated with LCH, the diagnosis was of LCH hypophysitis. In this is involved pituitary gland along with the stalk. Now, upcoming disorder that is very important is the IgG4 hypophysitis. In the IgG4 hypophysitis, it can involve the anterior pituitary, posterior pituitary, or the whole pituitary. So if the anterior pituitary is involved, there is hyperpituitarism or individual endocrine hormonal deficiency like hypothyroidism, hypogonadism. It can have a mass effect on the adjacent structures like optic chiasm. Now, if there's an infundibular neurohypophysitis, that is the posterior pituitary involvement, then the clinical manifestation will be diabetes insipidus. In panhypophysitis, both of them involved. That is why it is important in pituitary and sellar lesions that we need to know what kind of hormonal deficiencies are we dealing with. If there is hypogonadism or hypothyroidism, the lesion is more or less considered within the anterior pituitary. However, if there's diabetes insipidus, that means our focus of interest should be in the posterior pituitary as well as in the stalk. Now, IgG4 hypophysitis is a very rare entity. However, common radiographic findings have seen which have non-specific enlargement of pituitary gland with or without infundibular enlargement that is visible on both CT and MRI. And post-contrast will show enhancement. Now, other associated head and neck manifestation of IgG4 diseases should be considered, such as hypertrophic pachymeningitis. We will discuss it in later videos. Now here this was a patient. Now MR shows a diffusely thickened pituitary stalk and a slightly larger pituitary gland for the normal age. However, the signal intensity was normal on T1 and T2, and it shows an avid contrast enhancement. So with other features of pachymeningitis and other clinical manifestation, the diagnosis was considered IgG4 on histopath also. The histopath made the definitive diagnosis of IgG4 hypophysitis. Now, a very important thing that we can come across, this is a very emergency condition, that is the pituitary apoplexy. Now, it presents with a sudden headache and visual defects. The patient presents with sudden headache and visual defects. It can either be hemorrhagic or non-hemorrhagic. That is a very important point that we need to consider in pituitary apoplexy. Most of the time, there is a pre-existing macroadenoma. Now, risk factor, now here again, history is very important. There could be an ongoing treatment with bromocriptine or cabergoline. A patient could be a pregnant patient who suddenly presented with sudden headache and visual defects. In that patient, a pituitary apoplexy is there. The first we call it Sheehan syndrome, or the patient could be undergoing any anticoagulation treatment. Now, on T1, there could be variable intensity because if there's a hemorrhagic infarction, it could be hyperintense due to blood products. T2 is variable signal due to the because blood has a tendency of aging. The signal intensity changes as the blood ages. Now, on the T2 star, we can have blooming artifact due to active blood products. On post-contrast enhancement is variable. However, there is usually a peripheral enhancement. This is by peripheral rim enhancement. Why? Because the central gland could be infarcted due to hemorrhagic or not, hemorrhagic involvement of the pituitary gland. So there's a peripheral rim enhancement. On DWI, there's a restricted diffusion which is present in solid infarcted components. Now here, this patient presented with sudden visual complaint, sudden headache. You can see on SASH T1, there is a hyperintense area in T1 that is involving the pituitary gland with the supracellular extension. On axial T2, there is again a blood level, a hematocrit level, which you can see in cellular area. On post contrast, there was a peripheral contrast enhancement with infarcted gland, which is non-enhancing within. So all this with the clinical presentation, the diagnosis was pituitary apoplexy. Now, some benign other conditions, that is incidental loma. What is an incidental loma? An incidental loma is a radiological lesion that is found incidentally and is of dubious clinical significance. The patient came with some other complaint. You found it. This is a focal area of non-enhancement or hyperintensity in the gland. Now, again, less than 10 mm we call it microincidental loma, and more than 10 mm we call it macroincidental loma. Now, how to approach it? We need to suggest a hormonal evaluation for any hypo functioning of the pituitary gland and the prolactin level as well. If there is a macroincidentuloma, the chances are high that it can involve optic chiasm. So we should advise the patient to get the visual field testing. For follow-up for microincidentuloma, we follow up after 1 year, whereas for macro, we follow up after 6 months. Now, a variant that is very involving in whatever kind of surgery, whatever lesion pituitary gland is there, we need to always look for the ICA. Why? Because any surgeries would always involve that the ICA is in a very close proximity to the pituitary gland and the sellar area. So this is a kissing carotid. It means that the medially placed ICA in bony sella. The ICA are very medially placed, and it can mimic a pathology, or the surgeon can mistakenly injure, which can lead to a retropharyngeal doing a retropharyngeal transfer surgery, which is a very big blunder. If the intercarotid distance less than 12 mm, as you can see in the axial T2, This is the anomalous cavernous segment of the carotid that is very medially placed. We need to put it in the report. That is very important for the surgeon as well as for us, so that we do not confuse it with some other pathology. So that concludes the basic sellar lesion, the supracellular lesions. We'll discuss other pathologies of the neuro system in the upcoming videos.